So, good morning, good afternoon, or good evening, depending on where you're joining us from. I'm EJ Ashbourne, Executive Director of the Partnership for Quality Medical Donations. And on behalf of our entire team, I am pleased to welcome you today to today's Pillar Talk, Guidelines in Action, Advancing Quality through across Medical Donations and Missions. This is our first Pillar Talk of 2026, and it's part of our long-running series of conversations shaped by PQMD's expert network. For those of you who may be new to PQMD, welcome. And we're happy you're here, and welcome back to everyone else. It's always wonderful to see so many familiar faces. So PQMD is a global alliance of international NGOs and leading healthcare corporations working together to ensure sustainable access to quality medicines, medical devices, and health services for people affected by crises and for communities that are historically underserved. PQMD is marking its 25th anniversary this year, and over the past 25 years, PQMD members have been engaged with the most significant developments in global health, from vaccines and humanitarian response to disaster recovery and foreign aid programs. Our work today spans 6 core pillars: humanitarian assistance, health system strengthening, disaster response and preparedness, knowledge and innovation, climate and health, and of course, guidelines. So PQMD's guidelines for medical product donations, medical missions, and rare diseases, and by the way, those are 3 different sets of guidelines, lay out the standards and guidance for assuring the quality of donation practices. They provide a roadmap to ensure that products and services truly support situation and national priorities and health system realities. They are shaped and regularly updated by our NGO and corporate members, in coordination with partners and policymakers who rely on them every day in real-world settings. Over the next hour, you'll hear directly from PQMD members about how they use the guidelines to channel decisions, improve coordination, and strengthen service delivery. We will be dropping information and resources into the chat throughout the event. And as a reminder, this session is being recorded and will be posted. So please kindly remain muted throughout the program and then unmute when asking questions, obviously. And also, please take this moment to type your name and organization into the chat so we can just have an idea of who's in the audience. And lastly, I would like to thank our 25th anniversary Pillar Talk series partner, Children's International, for helping make this year's conversations possible. With that, I am pleased to introduce our moderator, Kavita Sood-Isaacs, Associate Director for Corporate Responsibility and Global Philanthropy at Baxter International, and she is also the chair of PQMD's Board of Directors. Kavita brings deep cross-sector experience and a long history of leadership within this network. She's focused on PQMD's impact at 25 years, and she is the perfect person to facilitate today's discussion. Over to you, Kavita. Thank you.
Thank you. Thank you, EJ. Welcome, everyone. I'm excited to be facilitating this conversation today. Our discussion, as EJ said, is about evolution and real-world impact, from early coordination challenges to delivering operational tools. So before I turn it over to our esteemed panelists, I want to share that our goal through this conversation is to celebrate what's been built, demonstrate how the guidelines work in practice, and reinforce how they can continue to be applied in increasingly complex environments. Put simply, our guidelines exist because improper donations still happen. And when they do, the cost is real: wasted resources and missed opportunities despite best intentions. So while our PQMD guidelines absolutely prevent harm and inappropriate donations, if you use them, you know they also enable excellence and they give organizations confidence. And with that, I'm excited to turn it over to our panelists to give you insight into how the guidelines are being applied today. So you have their bios already. So I'm going to begin by posing a brief opening question to all 3 of our panelists, Chelsie Ferguson, Bill Lynn, and Jodi Allison. So which PQMD guidelines do you represent today? Can you please share the guidelines, the perspective of those guidelines, and what problem they were originally created to solve? I will turn it over to you, Jodi, first.
Thanks, Kavita. So I am here to really represent the history of the guidelines. I was the first chair of the guidelines committee, which, by the way, I knew nothing about guidelines. At that time, it was called the Standards Committee. I also knew nothing about standards. So I kind of just fell into this role, but it was so incredible to be there at the very beginning when we were first launching into this. So I'll be kind of focusing on some of the historical pieces, given that this is now our 25th year at PQMD, which is incredible. And then also kind of a little tinge of disaster and how to use the guidelines during times of disaster.
Thank you, Jodi. Chelsie, I'll turn it over to you.
Yes, hi. My name is Chelsie Ferguson, and I currently work for Islamic Relief USA as Global Health Specialist, and I'm here to represent the PQMD Medical Missions Guidelines. The goal of the PQMD Medical Missions Guidelines is pretty simple. It's to ensure medical missions are ethical, coordinated, and truly beneficial to the communities they serve. Historically, medical missions were often well-intentioned, but not always aligned with local health systems. So teams sometimes operated without strong coordinations with the ministries of health, with long-term follow-up, which could unintentionally create the duplication or strain on the local systems. So these guidelines were designed to kind of shift that model more so for from short-term charity to long-term partnerships. They emphasize the alignment with the national priorities and proper standards of care, continuity and strengthening, not replacing the local systems. So for us at Islamic Relief USA, that framework was very critical. And through our global health program, we already had two strong pillars, long-term development health projects and our Gifts in Kind medical donation program, both aligned with the ministries of health and focused on system strengthening. But we did see a gap. So the donating medical equipment, supplies, and pharmaceuticals are all important. Funding projects is important, yet sometimes there is that final mile, whether it's CME, technical training, or addressing that specific service gap. So in some cases, it's also more urgent, right? So refugees and underserved patients may need surgeries or specialized care that they're never going to be able to afford or access. So without that targeted support, they may remain untreated, and that's where the medical missions came in. So for us, medical missions were never standalone trips. They've been designed to complete the circle and aligning with our GIK strategy, supporting the national priorities and strengthening health systems responsibly. So that alignment is exactly what the PQMD guidelines were created to promote.
Thank you, Chelsie. Thank you. I'm excited to hear more about your program as well. So let me turn it over to Bill before we start our specific questions. Bill, could you share what guidelines you're representing today?
Thank you, Kavita. Yes, I'm Bill Lynn, and I am leading the Rare Disease Working Group for PQMD. And one of the first set of activities that we embarked on was to review and look at the rare diseases guidelines. And just as a little bit of a background, rare diseases, by nature are unique. There are about 70,000 to 100,000, depending who you're talking to and what data you're looking at, of different kinds of rare diseases. And however, only about 10% of those diseases have approved treatments. So this makes it a very difficult product to donate and also to provide access to that medicine in low to middle income countries have always been a challenge, even for larger companies, all the way down to emerging biotechs with new technologies. So therefore, back in 2022, I believe, to 23, PQMD spearheaded an initiative called GARD Access, which was the Global Alliance for Rare Diseases. And in that capacity, GARD Access one of the priorities was to develop a methodology to help companies and organizations that want to launch an access to rare disease medicines program, especially in low to middle income country, to develop some methodology and a template so that whether, regardless of what organization you are from, large or small, they can follow a step-by-step process to launch an initiative and launch programs that will affect and impact the lives of patients living with rare diseases.
Thank you. Thank you, Bill. With that, you can see the landscape of PQMD's expertise from broad guidelines to specific use cases. So Jodi, I want to take it back to you for a moment and talk about, as you alluded to, when PQMD began, there were no shared guidelines. So looking back, what gap were the guidelines most urgently trying to fill, and why does that gap still matter today?
Yeah, so when I look back, 25 years, it's been a really long time. As the first chair of the guidelines committee, I think we didn't think that the system was broken because donations were not fully broken even back then, but they were chaotic and unorganized. And so there were incredibly well-meaning people, a lot of well-meaning people who were just looking for, I think, like a better way to work together as a whole. So our efforts then were much more reactive. So people had a surplus of generosity, but we didn't really have a map to lead us all to the right place. So donations would become, uncoordinated. There wasn't a common set of standards for any of us. So it was difficult even for incredibly well-resourced larger organizations to ensure that their contributions were like perfectly aligned with the people who we were trying to meet their needs on the ground, and just we weren't 100% aware of that alignment. So we wanted to always, of course, honor the recipients of our care. So we needed to move to something that was unorganized to a place of complete intentionality. And that's really what kind of came about with the guidelines. There was a lot of grit. There was a lot of innovation. We look at those guidelines now, which are just so strong, and just imagine like that was an empty page. There was nothing there. So that innovation and grit was super important. And it required everyone to have a seat at the table. So we had, obviously, corporations and NGOs had to come together and like build that trust and collaboration to really get behind creating this map that was going to lead us all to the place that we wanted to get to. So we had to work hard on a common language. There was a lot of common language conversations of like, who is a partner and what does partner mean? And do we want to use partner differently in this paragraph versus this paragraph? So this common language was a really big piece there. And then it wasn't really about logistics, though logistics are included, but really it was about the quality of the work and making sure that there was a collective excellence in everything that we were doing. I will also say that this becomes even more important during times of disaster, because that's kind of when the whole world is looking at our sector, looking at what we're doing, seeing this tragedy that's unfolding on their TV screen or their computer screen, and they want to take action. And sometimes that action can lead to unintended consequences. So the guidelines during disaster were always from the beginning something that we focused on making sure that we could get those guidelines created in a way also where everyone can understand them. So this is a complex thing that we do. Product donations are really complex in the healthcare space, but we wanted to make sure that the language was also simple enough that anyone could understand it. So even really well-meaning small groups of citizens could read these guidelines and understand what to do, especially during times of disaster. And obviously they are still this map that we're all looking toward to just guide us in the right direction. That has not changed. What's changed is the refinement of that, where we went from focus mostly on pharmaceuticals to also including other types of healthcare products. We talked about rare diseases now. short-term medical missions as well. Like all of the different aspects of the guidelines have really just been further refined, but I think they still hold that element of also being really easy to understand. So if you're a small group that wants to start doing some sort of donations, whether on the corporate side or the NGO side, you can really understand those complex challenges that we all experience with healthcare donations.
Thank you, Jodi. You hit on an important point there with common language, because from I can share from a corporate perspective with Baxter, one of the ways that we build trust and understanding with our partners is knowing that PQMD members and NGOs conduct a self-certification every year, whereby they look at the guidelines, review their processes, touch base with ethics, compliance, trade, legal internally to ensure that they're adhering to those standards. So that common language really allows us to create a base of trust and partnership. Which is a huge benefit to being a part of the organization, and that the guidelines have provided today as well. So thank you.
Absolutely.
Chelsie, I want to turn over to you. You mentioned your global health initiative, and Islamic Relief really went directly to the medical mission guidelines when launching that initiative. Can you share what role the guidelines played in shaping your approach before your first mission ever took place?
Yeah, so medical missions has always been a long-standing vision of our CEO for many, many years. There was always a desire to expand our global health footprint beyond just the donations and development programming and kind of move more deeper into clinical engagement. So, turning that vision into something responsible and sustainable required structure. So when I joined the organization about 3 years ago, uh, I was asked to help operationalize that vision. The very first place I went to be honest, was the PQMD Medical Missions Guidelines. The guidelines were instrumental in, moving us from a conceptual idea to more of an operational reality, rather than just navigating the complexities of launching a global health initiative through like trial and error. We used the framework as more of a blueprint, which was extremely helpful. It helped us identify the critical pre-mission steps that ultimately determine whether a mission strengthens the health system or unintentionally disrupts it. So, at the same time, we were not starting from scratch per se. Through our global health program, we already had two strong pillars in place. As I mentioned before, we have our gifts in kind medical product and pharmaceutical donation program, and also our long-term development health projects. So through these efforts, we had already built strong relationships with ministries of health, hospital leadership, and trusted local implementing partners. We had already conducted the needs assessments aligned with the national priorities and worked closely with ambassadors in the Washington, D.C. area to kind of ensure the government to government visibility and support was there. So that foundation was critical because of our gifts in kind work. We understood what equipment gap existed, where stockouts were occurring, and which facilities had capacity constraints. Because of our development programming, I would say they guided us in defining our clear scopes of work, ensured the proper credentialing and in licensing for our providers, coordinating early with the ministries of health, engaging with those trusted local vendors, planning for continuity, and building on monitoring and evaluation into the process from the start. So they also helped us anticipate blind spots, such as post-operative follow-ups, supply chain integration. You have the cultural considerations, obviously, and ensuring that we were complementing, not competing with local providers. That was also key. So in many ways, the guidelines gave us the discipline to kind of slow down and build correctly before launching our first mission. They ensured that medical missions were not standalone trips, as historically they had been for, previous organizations in the past, but rather than just an extension of our existing global health strategy. So, by the time our first mission was deployed late last year, it was not an isolated effort. It was more built on years of relationship building through our GIK program, alignment with the national health priorities, strong diplomatic engagement, which has been a key player for us, and then the development first mindset. So the PQMD guidelines helped us weave through all of that together into a cohesive, responsible medical mission model from day one. And that foundation continues to kind of shape how we approach every mission today.
Thank you, Chelsie. I think it's so, first of all, kudos to you and the team for getting this program off the ground. And I think it's so important to note your use of the guidelines, excuse me, was 360 in building this program that fit into your existing strategy, but also something you touched upon was the sustainability of the work and in making sure that medical missions weren't one-off donations, but rather a part of your overall approach. So thank you for sharing that, and kudos to you again. Bill, I'd like to turn to you in terms of the rare disease guidelines. As you mentioned, these donations raise unique and ethical and equity challenges. So could you speak to how the guidelines help organizations navigate fairness, transparency, and long-term responsibility in these highly complex situations?
Yeah, that's a kind of a loaded question, especially for rare diseases, right? But yes, first of all, I think being the newest kid on the block, the last set of guidelines to be instituted into the PQMD portfolio. I want to go back on what Jodi and Chelsie had already said about the quality and the health system readiness that is required for any medical product donation, and especially for rare diseases where the biggest part of the gap is really on countries' readiness, their policies and their infrastructure, whether they are able to have effective diagnosis and treatment, whether there are financial and and other reimbursement and social support for the patients living with rare diseases. So the components that Chelsie talked about in terms of the diplomacy and the engagement with the government is very, very key and necessary when we're talking about sustainability and long-term treatment of these diseases, because there are two things that make rare diseases so fraught in these low to middle income countries. One is that there are actually three things. No policies are in place. Two, the products are very expensive, and so making sure that there's financial viability and reimbursement and other insurance coverage for the treatments is also key. And then third is the long-term requirement for these products, because a lot of these patients require the treatment pretty much for the rest of their lives. So in the minds of many organizations, and also from a global health perspective, and this is one of the things that I've always said, is that donation is not a global health solution. We need to put something in place that whereby countries can be self-sufficient, and patients can be self-sufficient through the whole access program from cradle to grave. So one of the first things that is necessary, and that's built into the guidelines, the first step in developing any access to rare disease medicine program is to get a good understanding and clear understanding of what is the situation on the ground, what is the ecosystem and landscape that you're bringing that particular program into, so that you either the donors or the implementing organizations have a good long view of what it means for the product to be sustainable. So even though the situation analysis is the first step and the organizations need to build in sustainability up front, the other sections of the guideline, which includes project design, project strategy, program development, program implementation, each one of those other sections, all the other sections also take into consideration and keep focus on the equity and ethical process, equanimity, as well as sustainability. So again, for the guidelines, the sustainability piece is built into the entire process.
Thank you, Bill. That you're highlighting something that I think it's important to note, which is the guidelines are helping build infrastructure as a part of health system strengthening. Alone as isolations, the donations aren't the solution. However, the guidelines are providing, as you said, the design, implementation, considerations to think through how this fits as a part of the larger strategy. And I think that's important to note. Not only is it giving best practices, but those considerations for the larger ecosystem, as you mentioned. So thank you for providing that insight. Jodi, I want to go back to you for a moment in terms of what you already spoke to a little bit around disasters. And in complex settings like that, disasters can involve ethical decisions around destructions or delays or saying no to donations. So could you speak to how the guidelines help organizations lead from a place of responsibility and strength rather than a deficit?
Yeah, I mean, when a disaster happens, the last thing that any of us want to say is no. Like everyone wants to jump in and help because we're seeing these like incredibly compelling images that are right in front of us all the time. And the world is watching us at that point. Like everyone is watching us, your stakeholders, your leadership, outside people just around the world are watching to see what we're doing. So there's this natural instinct of like, we have to move as quickly as possible. We have to go as fast as possible to solve this problem. But I think what we've learned over the last 25 years here at PQMD is that more is not always better and fast is not always effective. So we have to focus more on the things that really matter. The guidelines kind of take us to this place of responsibility and strength. So there's no deficit there. We really are more focused on what's the right thing to do in the moment and not what's the quickest. So when we have to make this really hard call to delay a shipment because something's happened, cold chain on the ground is compromised or logistics are not possible, we have to keep going back to why we're doing this to begin with, right? At the first and foremost, do no harm. Like that's just part of the medical culture that we're all a part of. And so moving away from that decision that we might make in an emotional state or because of expectations of the outside world who doesn't really know the complexities of what we do, like that's the piece that I think the guidelines allows us to do. So we aren't saying no to helping, but we're saying yes to the safety of the patient, the integrity of the local response, respecting cultures on the ground. That's what we're accountable to because we are accountable and responsible to the guidelines. And so I think that's where kind of the grit that I mentioned earlier really shows up because it takes leadership to explain to stakeholders that a delay is a form of protection. It's not a no, it's just we're protecting the people that matter most in times of disasters. So I think the guidelines allow us to, it actually ensures that we're not acting out of a deficit mindset where we feel like, oh, something is better than nothing. We've all heard that at some point, when it comes to donations, like, oh, well, getting something there is better than nothing. That's not reflected in our guidelines, right? Like that is not a pillar of the PQMD community. And so that allows us to act and kind of empowers us out of a place of stewardship in standards. So we want to protect the last mile. We want to protect the patient. We want to protect the culture of the places where we're working. And all of those things change during disaster. I mean, it just depends so much on where the disaster is taking place. If it's a natural disaster, if it's a humanitarian crisis, all of those things have to be taken into account. And all of those things are reflected in some way within the guidelines, just to make sure that we're continuing to think through those things every single time that we respond in any type of disaster.
Absolutely. Thank you, Jodi. I think I've learned so much too from our partners and the guidelines about how to communicate with my stakeholders internally in that process. And, when one of my commercial or business partners comes to me and says, I want to make a donation, I will go back and say, we will evaluate this to make an offer, right? And it seems so fundamental, but I think the guidelines say somewhere that this needs to be made out of an expressed need and a request, right? It's so foundational, but it's so important to come back to that. Is their community request and need identified, and are they asking for the product, right? And starting there.
Yes. And I think that's a great example, Kavita, of the well-meaning people. Like none of this is done out of irresponsibility from anyone who's doing the wonderful things, right? The religious groups that are pulling together clothing or Band-Aids, they're doing it out of such beauty inside of their souls. And so we want to honor that, but also say, that's actually not what needs to be done right now. Like probably donating cash to a reputable organization that really understands complex disaster response is probably your best option. So save your money on the Band-Aids and instead, donate that amount of money to a reputable organization. I think that's it's the well-meaningness that's really beautiful, but can turn into tragedy if it's done incorrectly. And that's a great example, even internally within all of our organizations. I think we have that really well-meaning, wonderful people, but just guiding them back to some of the core foundational pieces of the guidelines and proper emergency response is what you did in that situation. And that's what, I hope we all do as organizations that really want to do it right and well.
Absolutely. Implementation is hard, and these guidelines are designed for real world constraints. And so these examples help shed light on the ways that we can adapt and improve with the right guidance. Chelsie, I wanted to ask you another question. Thank you again, Jodi. In terms of the work that you're doing, you obviously had to work and collaborate with so many different diverse stakeholders, doctors, lawyers, and partners around creating your program. And you shared with me some work that you've recently done with UNHCR. And so I was hoping you could share how the guidelines helped you convene around a shared standard.
Yeah, so applying the guidelines really in politically complex environments, including alongside UNHCR, has really reinforced just how important a shared framework is. So first, because the guidelines are evidence-based and internationally recognized, they kind of provide the institutional credibility. So as a newer actor in the medical mission space, we were able to kind of anchor ourselves in an established standard rather than presenting ourselves as improvising. So that immediately positioned Islamic Relief USA as a serious, responsible, and competent partner in conversations with, doctors, legal teams, Ministry of Health, and obviously the UN agencies. So secondly, I'd say the guidelines created that common language, which was very important, especially given all of the actors that are involved in a medical mission, right? So when you're coordinating with physicians, lawyers, local hospital administrators, government officials, each group kind of views risk and success differently. So physicians focus on clinical outcomes. You have lawyers focusing on, the liability and compliance components. You'll see government officials focus on sovereignty and national priorities, and then, you have the UN actors focusing on protection frameworks. So the guidelines allowed us to align all of those perspectives under one shared standard. They helped us clearly articulate our non-negotiables, which was very important from the beginning. Services must be ethical and legally compliant, coordinating with the authorities, culturally sensitive, and rooted in the dignity part, which is very important for our organization. So that clarity reduced the ambiguity, for lack of better words, and it prevented the misunderstandings before they could escalate. They also kept us centered in, I would say, uh, politically sensitive settings, in complex environments, especially when working with refugee populations. There can be shifting narratives, heightened sensitivities, and layered stakeholder dynamics. So the guidelines gave us something neutral, which is extremely important and a principle to return to when navigating those choppier waters. Instead of opinions driving decisions, we could point back to established best practices. For example, during our mission in Jordan recently, in November, we were we were working with Syrian refugee populations in coordination with UNHCR and the local Jordanian physicians. So the guidelines helped us anticipate the cultural, legal, and operational complexities early. We recognized that our volunteers were entering a context shaped by the displacement and trauma, language differences with specific regulatory frameworks. So to prepare responsibly, we coordinated with the local UNHCR staff in Jordan to conduct the specialized orientation for our team. The session addressed not only just the formal laws and regulations, but also the implicit social norms, cultural sensitivities, once again, and the protection considerations that were important. So the proactive preparation ensured our volunteers were equipped, not just clinically, but socially and ethically. Ultimately, the guidelines helped us align those diverse stakeholders by keeping the mission anchored in shared humanitarian principles that, we're all aware of, the humanity, service, protection, and dignity, while safeguarding volunteers and beneficiaries without compromising quality of care. So in politically complex environments, that shared anchor is what makes the alignment possible.
Thank you, Chelsie. I love that term, shared anchor. I think that's so apt for how to describe the guidelines and what they've been for us over the last 25 years, and so clearly demonstrated in your use of it. Bill, I want to turn to you for another question or reflection. You've mentioned that unlike acute donations or mission trips, rare disease treatments can mean lifelong commitments. So I'd love to hear, could you share how the guidelines, the rare disease guidelines, address quality control, sustainability, and the health system readiness, and kind of what do you see as next for the rare disease guidelines?
Well, so it's great to hear Chelsie describe, her journey and experience in Islamic relief on, the medical mission and how, she navigated that in one of her first medical missions, because that is exactly where we are currently with the Rare Disease Working Group and the guidelines. So originally, the guidelines, as I said earlier, came from Guard Access. And at that point, at the late stage completion of the guidelines, Dr. Patty Tracy took the guidelines to Brazil and did a field test with an organization called Caçadores Raros. And it was very well received, and it also confirmed that many of the components of the guidelines, as well as the priorities outlined in the guidelines on sustainability, quality, and engagement, were spot on. And that field test involved a lot of the people and organizations that Chelsie mentioned regarding, the ministries of health. There was academia, there were patients, patient advocacy groups, international organizations, and others that were involved in that field testing. So it was a very robust exercise that was undertaken. So now that after it came to under the stewardship of PQMD, and this is basically, I guess I would call it, Rare Disease Guidelines 2.0. The working group has gone and did due diligence on reorganizing and restructuring the guidelines so that it reflects the entire process of developing an access to medicines program. And as such, my comment earlier about having somebody like Chelsie, the shepherding a program through using the guidelines would be the next opportunity for the working group. And also, one of the things that the working group has embarked on and has agreed upon is that we should be developing specific tools like checklists and decision trees within the guidelines so that it will facilitate organizations and implementation partners when they are using the guidelines to assess where they are and to develop a program. And I want to give a shout out to one of the working group members, Greg Fagan from Sanofi, took the initiative and developed a very robust tool for situational analysis in the rare disease guidelines. And I'm actually quite excited to see where we can actually field test and apply that in a use case for the guidelines moving forward, because we are certainly there at this point. And one of the next steps for us at the working group is to solicit and engage partners and organizations to see who is where in their implementation cycle, or whether there are initiatives that they are willing to and are in the process of embarking on, so that we can actually field test this, the tools that are being developed by the working group.
Thank you, Bill. Thank you for giving us an inside look at what's next and how these are going to continue to evolve and be adapted for real world environments. It's helpful to see, and just another example of how these are living, breathing documents that continue to improve the work that we do. I want to share that we have a few past chairs on the line with us. We're honored to have them here, and we've actually invited them to share some reflections as well, given their leadership in helping shape the guidelines. So we have Ann Nowakowski and Lydia Amarty Williams. So I'm going to invite them to introduce themselves, and some thoughts also from Courtney Suda, and reflect on the question: in helping to shape the guidelines, what are you most proud of, or how have the guidelines impacted your own role at your respective organization? So Ann, can I ask you to chime in?
Yeah, so I'm Ann Nowakowski. It's really such an honor to be here and celebrating this major milestone for PQMD. 25 years is quite an achievement. It was such an honor for me to be part of the early PQMD guidelines. there's nothing I can say that hasn't already been said by this very esteemed panel. Just my own experience is that working on these complex challenges and gnarly real world problems really did require collaboration across sectors to develop standards that are both practical but also principled and address systems level issues. And that's not unlike what I am working on today. So I now work with Sage Bio Networks as a product strategist, where we are sharing biomedical research data with researchers from around the world. So where PQMD developed guidelines that were focused on the movement and quality of products, I now work on guidelines and standards for the movement and security of biomedical research data, biomedical research assets. And interestingly, that's done in the form of like passports, visas, and declarations regarding the use of these research assets. So where PQMD has been focused on like ethical and responsible use and of products and medical donations, I'm focused more so now on the generation of new knowledge in an ethical and responsible way. In both instances, we want to ensure that we are delivering consistently from good intentions to good outcomes. So I think that the work that and the experience that I gained from PQMD has been really phenomenal throughout my career.
Thank you so much, Anne, for your leadership and sharing how the guidelines continue to shape the work you do today. Can I ask Lydia as well to join us?
Oh, so hi everyone. I'm Lydia. Some of you will know me. I used to work at IHP for almost 7 years and was the guidelines chair 2 years ago. And I was on the guidelines committee for a while. And I think what I really appreciated about the guidelines was how dynamic they were, and that actually they're not just one single organization creating some rules. It is a hive mind coming together from experience to actually create a living document that makes a difference in the work that we do. So as I look back, I don't do much with guidelines or product donations in my current role, so I can't talk too much to how they impact my role currently. But I distinctly remember that the guidelines were a gold standard for us at IHP. And being able to contribute to that was really important for our work. So for me, I'm just really pleased to see that they're continuing to be that gold standard for product donations and are helping other organizations make the right decisions when it comes to really critical medical donations. So really proud to be a past guidelines chair, and I'm really pleased to come here and say that. So thank you for inviting me back.
Thank you so much, Lydia, for your commitment and for helping us celebrate today. We really appreciate you. And Julie Marie, I think, is going to share some thoughts from Courtney Suna, who wasn't able to join us live.
Yeah, Courtney's out today sick, unfortunately, but she is our current chair of the Guidelines Committee and also the director of Global Community Investment at AstraZeneca. And really, in addition, I think her comments really showcase an important corporate perspective. So she asked us to carry them forward today. I'm just going to present a summary of what she sent to us. So PQMD and the guidelines has been an invaluable tool for ensuring AstraZeneca's own internal guidelines and SOPs were in line with industry best practices and useful to their internal teams and partners. When Courtney stepped into a broader role at AstraZeneca, she was looking for global product and started looking after global product donations as a whole and humanitarian and disaster relief. It was immediately clear to her that their internal processes and policies were very broad, general, and not fit for purpose to ensure that they were providing global donations in a way that was efficient, appropriate, measurable, and met their own internal processes for paths and approvals. So she decided to build out a new global product donation process from the ground up. And systematically, she engaged with stakeholders at AstraZeneca that included compliance, operations, product teams, country colleagues, distribution, sustainability, and others. And then she also worked within the PQMD network and engaged member colleagues that fed into her process for proposed changes to their guidelines processes. And the result was a lengthy and detailed SOP that allowed the AstraZeneca team, not just herself, but any member of the team, to offer product donation to an approved partner, with a key aspect being that the approved partners must be members of PQMD, and they must certify that they confirm and adhere to the PQMD guidelines. And that strengthened process was presented to the Board of Sustainability and the board chair, who unanimously approved, solidified their new policies and practices. And she wanted to share that as a result of the pilot, within the first 6 months, they have already donated over $10 million worth of products for humanitarian purposes. 100% of those were from excess stock that would have been otherwise destroyed. And then lastly, she wanted us to say that none of this really would have been possible for them without the PQMD member input from the team to lean on and to guide them, and that the PQMD network, that is, and the comprehensiveness of the guidelines themselves. So it would have been much better to hear from Courtney, but I'm sure she's pleased that I'm carrying it forward today.
Thanks so much, Julie Marie. And Courtney did say that she's happy to speak with anybody or share more insights from her process, just given how much the network has given to her. She wanted to be able to give back as well. So thank you, Julie Marie, for that. Before we close out, I wanted to pose just a rapid closing question to our panelists. So Jodi, Bill, then Chelsie, maybe you can have you share, as you look at the 2025 guidelines, what is one way organizations can actively use or share them to improve quality in the year ahead?
Do you want me to go first?
Yes, go ahead.
Okay, awesome. So I think the first thing is to just socialize them broadly. Like, I would get them out to every single person that you know that works in this space, right? So your CSR people, your disaster response teams, logistics partners, any like local government liaisons that you're working alongside, donors in some sense. Like, we want to speak the same language of quality, and we want to eliminate all of the unorganized, friction that can slow us down, especially during a crisis, but even just in our normal work. And then I would say, look at them often, review. So we do that all of the time at PQMD, but just make sure that you're reviewing them and then that you're standardizing them across your organization. This comes with work, right? Like, quality isn't something that just instantly happens. It's a habit, and we have to practice it daily. So make sure that you're standardizing it, in your blue skies and in your gray days, just to make sure that no matter what, you're going back to those guidelines as your North Star.
Thank you, Jodi. Bill?
So yeah, certainly echo Jodi's sentiments regarding the guidelines. It is a living document, and it is we're going to continue to build on it, especially for rare disease guidelines. We are still just in a very fledgling stage of building that knowledge base and contributing to refining the guidelines. So, I'm going to be shameless here in giving the Rare Disease Working Group a plug and asking, those participants on this call, as and the audience, if you have any desire or have any interest in rare diseases and would like to let us know what you thought of the panel today regarding rare diseases, or if you want to be engaged, please feel free to reach out. I think PQMD has my contact information. But we are at this point now where we need to engage partners on the ground and really get to overlay the use cases onto the guidelines. And as Kavita said, implementation is hard, but I don't think hard has ever deterred anybody, any of the members of PQMD. So I have no doubt, we'll move ahead. Thank you.
Well said, Bill. Thank you. Chelsie, over to you.
Yeah, I don't know what is honestly left. You guys said it so beautifully, but I do want to say that, as Jodi mentioned, the more that we get them out and the more broadly that we share these, they really truly become valuable between all different kinds of stakeholders. So whenever I have the opportunity, I typically try to, tell people about these guidelines and that they exist. And for them to review them. And then also, I would say, building off of this, global health changes by the day. How we implement these things can change, and making sure that these guidelines reflect that. I think that's something that, PQMD is proud of, because we have teams dedicated to making sure that these stay current and that they reflect global health as a whole, as we enter a lot of different types of situations, right? Either politically or how pandemics happen and whatnot. So I did want to kind of throw that in there. But other than that, I think everybody was able to speak on it pretty well. So.
Thank you, Chelsie. Thank you, Bill and Jodi, and to all of our panelists and past chairs. I will just take a moment to close us out. I believe there's a lot of links in the chat and maybe some additional questions. So please encouraging everyone to go over to the COP or reach out to PQMD or us to continue the dialogue. As EJ and our speakers have said, these are truly living standards. They're stewarded and shared by serious but practical global health partners who use them and challenge them and adapt them to fit our needs. And I will state the obvious, which is, for those of you just getting to know PQMD, it's worth saying that this organization was founded 25 years ago by extraordinary people who cared about quality, accountability, and learning together. And where we started with the guidelines and where we are today, we've just really continued that 25-year tradition that continues to show up in all of our work. So I will reiterate what our panelists have said. I hope you'll use them. I hope you'll read them and challenge them and help us to continue to grow as we champion quality and really put the quality in our name. So with that, I will flag that there is just going to be a 1-question Zoom survey that pops up. We hope you will take it. And thank you again for joining us to celebrate 25 years and the guidelines.